Hi there, I'm Dr. Harris and this is my submission of the shoulder exam. Hi there, nice to meet you. I'm Dr. Harris. Today I'm going to be examining your shoulder, which means I'm just going to take a look at your shoulders, have a feel of them, get you to do some movements and some different movements just to assess all the function within your shoulder. Is that alright?
Yes, okay.
Before I start, have you got any pain anywhere?
No.
No, good, alright. So first of all, before we focus on your shoulder, I'm just going to have a look at your neck, your cervical spine, if that's alright. If I can get you to turn around, I'm just going to feel your spine to begin with, and no pain in your spine?
No.
No. Right, so I'm just going to feel down the bony aspect of your spine, is that alright?
Yes.
And the paraspinal muscles, is that okay?
Yeah. And
this side as well?
Yeah.
And you've got no tingling or funny sensation in your arms?
No.
No. Can you put your chin to your chest for me? Lovely. Can you have a look up at the ceiling? Can you look over this shoulder for me? Can you look over this shoulder for me? Ear to this shoulder and ear to this shoulder. Any pain on movement there?
No.
No, that's fine. You can turn around for me. The next thing I'd like to do is just assess your core stability. So this is really important in assessing because it links in with shoulder movement as well. So the way I'd like to do this by assessing your core stability is get you to stand on one leg and crouch down as far as you can. And the other leg. So slight wobbliness on core stability. But that's fine. Right, so the next thing I'm going to do is just take a look. So I'm going to inspect the shoulder area. If I can get you to turn this way for me. So I'm starting off looking for any obvious deformities. Is there a nice even shape to the shoulder? Is there any evidence of any dislocation where the rounded contour of the shoulder would be lost? There's no obvious scars that I can see from previous surgery or injuries. The clavicles are in the same alignment. And again, I'm looking at the muscles for any muscle wasting in the biceps, shoulder area, and also the pectoral area as well. If I can get you to turn around for me. Just going to inspect the patient's back. So again, looking for symmetry in the scapula, the shape of the shoulder, and any obvious muscle wasting or scars, of which there's none. That's great. You can turn around and face me again. So the next thing I'm going to do after inspecting the patient is palpating the shoulder area. For the purpose of this video, obviously with a real patient in a real consultation, I would do both shoulders. However, for the sake of the video today, I'm just going to focus on the patient's left shoulder. So I'm going to start at the medial aspect of the clavicle and work away along. Any tenderness there?
No.
Working along from the clavicle to the AC joint. Any pain in there?
No.
Down over the acromion, is that alright?
Yeah.
Over the humeral head, any tenderness down here?
No.
Okay, fine. Right, getting you to turn around. Again, continue my palpation over the bony landmarks of the scapula. Any tenderness along here?
No.
That's fine, lovely, turn around for me. So I've now inspected the patient's shoulder areas, I've palpated for any tenderness, so now I'm going to get the patient to do some movements. So if you turn forward for me, I'm just going to get you to do some movements. So the first movement I'd like you to do is give your hands out to your side and reaching them above your head, please. Any pain there at all?
No.
No. Patient's got full abduction, that's great. Back down to your side. And then looking for flexion, so bringing your arms up ahead, see how far you can get them up. Is that alright? Any pain there? No. So again, full range of movement and reaching out to the back as well. Lovely. Any pain there? No. To look for internal and external rotation, I'd like you to go into the Howe position with both arms. So just a little bit higher in this area, please. And for external rotation, just want to see how far you can get your hands backwards, so rotating your shoulder round. Excellent, so a good range of movement there. And then for internal rotation, if you go the opposite way and see how far you can get your hands down to the back. Excellent. If you turn around for me, still looking at internal rotation, I'd just like to see how far you can reach up your back with your hands. So this is a good way of assessing internal rotation, and then with the other side, because you can compare both sides together, so both sides are equal with good range of internal rotation. Now, I've got the patient to do these movements actively first. If there was any limitation in these movements, I might want to assess them passively, so me assisting the patient in these movements. As in this case, the patient has full range of movement. I don't feel there's any need to do that. However, what I will do is focus in on the shoulder joint and just look at the glenohumeral joint. So in this case, again, I'll just focus on the left shoulder, but what I'm going to do is just stabilise the scapular area, or hold my hand over the area so I can feel movement in it, and get the patient to do these movements again. Once I can feel the scapula moving, this is the end of the glenohumeral joint movement. So I'm going to place my hand over your shoulder, and just what I want you to do is to bring your arm out to the side again, like I asked you to before. So at this point I can feel the scapula moving, so that's the end of that range of movement, which is normal. And then forward for me, please. And stop there. And then backwards for me, please. Stop there. And then go back into that how position. And go backwards as far as you can. Great. And then again, and as forwards. That's great. So on assessing the patient's movement at the glenohumeral joint, he has full range of movement. Staying with the scapula, I want to look for any dyskinesia, or any abnormal movement in the scapular joints. In order to do this, I need to assess the patient from behind. So I'm going to get the patient to turn around and do some movement. So again, on my inspection, I looked for any asymmetry in movement of the scapula, or any difference in muscle tone or deformity. There's nothing which I can see again now, but I'm going to get the patient to do some movement. So the first movement I'd like you to do is to bring your shoulders up towards your ears. So again, I'm inspecting and looking for the movement of the scapula. And then if you bring your shoulders down and drop them as low as you can, that's fine. And then if you can curl your shoulders forward, again looking for the movement of the scapula, and then bring your shoulders backwards. Lovely, that's brilliant. So I'm going to get you to do these movements again, just with your arms in different positions. So the next time I'd like you to put your hands on your waist, please. Lovely. So again, shoulders up to your ears, thank you. Shoulders down, shoulders forward, and shoulders back. Again, there's no abnormality. The scapulas appear to be moving in symmetry. And the next one is just putting your hands out front like Superman. So ears up, shoulders down, forward, and backwards. That's excellent, thank you. The last thing I'd like to do when assessing the scapula is the press-off test to look for any winging of the scapula. So if I get you to take a step towards the wall, place your hands on the wall like the press-up position, and push against the wall for me. There's no evidence of any winging of the scapula, which is good. It's fantastic. While still assessing shoulder movements, I'd like to look and focus on the rotator cuff muscles to look to see if there's any evidence of any impingement of these muscle tendons. So out of the 4 rotator cuff muscles, I'm going to focus on teres minor and infraspinatus first, and the test for this is resisted external rotation. So if I can get you to hold some drinks for me, elbows in at the side for me, and what I need to do is push it out against my hands. Is there any pain there? No, good. The next test I'd like to do is for subscapularis, which is placing hand on your tummy for me, and this is looking for resisted internal rotation. So I'm just going to place my hand in between and just want you to push in for me. Thank you. And then do it on the other side. Excellent. The last rotator muscle, rotator cuff muscle I'm going to look at is the supraspinatus, which is the empty can test. So if I can get you to hold your arms out in front of you, please, and just bring them out slightly in abduction, that's great. Pour your drink away, keep your arms there, don't let me push your arms down. Any pain there? No, good. So my tests have shown that there's no evidence so far of any tendinopathy and pain on assessing these rotator cuff muscles. Another test to look for any impingement is the Hawkins-Kennedy test, where I'm going to get the patient to abduct their arm, put their arm into internal rotation, and I'm just going to feel over the greater tuberosity. Any pain in there? No. So again, no evidence of any impingement. To summarise so far, I've inspected the patient, I've palpated the shoulder, I've got the patient to do some movements, I've looked at the scapula and the rotator cuff muscles. The next things I'd like to move on to are looking for any biceps tendinopathy, looking at the acromioclavicular joint, and looking for any slap tears and any apprehension. So if we move on next to the acromioclavicular joint, patients may experience pain there if there's any laxity in the soft tissue structures or any arthritis. A way to assess this is the scarf test. So again, I will just assess the left side. Scarf test involves if you can put your left hand over your shoulder like you're throwing a scarf over. Do you experience any pain in this area? No, so this scarf test is negative. Moving on to looking for any biceps tendinopathy, what I will do is get the patient to resist pronation of the forearm while palpating over the biceps tendon. So if you bring your arm up like this for me, and what I want you to do is turn your hand down to try and face the floor against my hand. So I'm just feeling over the biceps tendon there. Is there any pain in there?
No.
No. So there's no evidence of any biceps tendinopathy. In order to assess for slap tears, O'Brien's test is used. So first of all, for O'Brien's test, if you just turn to face me, so we'll focus on the right hand side for all of the camera. So what I'd like you to do is abduct, flex, so bring your arm forward for me. I'd like you to bring it just over towards you a bit, and I want you to internally rotate, so pull it around that way. Keep your hand there, don't let me push it down. Have you got any pain?
No.
If the patient had pain, what I would then want to do is assess the patient in external rotation, and again pushing down. Is there any pain there? No. So at a positive O'Brien's test, they would feel pain on internal rotation but no pain on external rotation, and this would be evidence of a slap test, slap tear. Finally, I'm going to move on to assessing the patient for any instability in their shoulder. This may cause previous dislocations. So patients who might be more vulnerable to instability within their shoulder joint may have evidence of hyper flexibility. In order to assess this, may I have a look at your hands? I'm just going to try and see how much movement you've got in your fingers. There's resisted movement in the fingers, which is normal. Are you able to get your thumb down onto your forearm?
No.
No. And if I get you to hold your hands both out straight in front of you, there's no evidence of any hyperextension at the elbow joint, so no evidence of any hyperflexibility. In order to assess for any instability at the shoulder, we would do the apprehension test. So again, putting the patient into the how position. Again, I'm just going to assess the patient's left shoulder for this case. And what I'm going to do is place my hand over the posterior aspect of the shoulder and just push the hand backwards. Is that uncomfortable?
No.
Is there any pain there? No, that's fine, good. So there's no evidence of any apprehension at all. So in summary so far, this patient, I cleared his cervical spine. He showed evidence of some poor core stability, but on palpation, inspection and movement, he has no deformities, no pain and full range of movement. On special tests, looking at the rotator cuff, the biceps tendon, the acromioclavicular joint, and looking for any slap regions, there was no evidence of any abnormalities. To complete my test, I would want to perform a full neurological examination of the upper limbs. This would involve looking for tone, power, sensation, reflexes and coordination, and that would complete my exam. Thank you very much for your time today.
Thank you.